hallmark for nephritic syndrome is hematuria. Okay, so when the patient has a rusty urine, then the condition is so. There are glomerular diseases that fall under the nephritic syndrome, and there are glomerular diseases that fall under the nephrotic syndrome. And there are, well, in medicine, there is no clear cut delineation, but there are some diseases that fall under the two. Are we okay so far? Yes?
Yes, Doc.
I cannot hear you.
Doc.
Yes.
Okay.
Doc.
Now, may I ask you what is the ultrafiltrate of blood? Anybody?
Hindi rin, Doc.
Ryu, are you there? What is the ultrafiltrate of blood?
Hindi rin, Doc.
Urine, Doc.
Urine is. Are you asking me or are you giving me an answer?
Hindi rin, Doc.
Urine is correct. Okay. So I need you to trace the passage of urine from the glomerulus to the loop of Henle to the distal collecting tubules to the collecting tubules and the other ureter and whatever. Okay. Okay. There are some terms that I would like to introduce. Number one is azotemia and uremia. Now, azotemia is pretty much a laboratory diagnosis. Okay. So, are you familiar with your NPNs, your non-protein nitrogens? Yes. Let me ask somebody. Tom, are you there? Tom,
Yes, Doc.
do you know your ABCs? Yes. Tom, do you know your ABCs?
Is that the for the the NPNS, the one you mentioned earlier?
Yeah. So you have the first letter A. What follows next? Oh, don't give yourself a hard time. Let's ask Wilhelm. Wilhelm?
A for ammonia, Doc.
Okay.
Blood urea, Doc, for B. Then
Okay, so
for C, Doc.
okay. So the ABCs for your NPNs are ammonia and amino acids. Okay, and then B, blood urea nitrogen and blood uric acid. And then C is creatine and creatinine. So any value that is increased will result in a state of azotemia. Do you follow me? So any value. So pretty much azotemia is a laboratory diagnosis. Are we okay? Yes?
Yes.
Yes. Okay. Now, azotemia plus clinical signs and symptoms will result to uremia. So you have not been in the wards yet, but when you have a uremic patient, When you were still young, did you bedwet before? Yes, everybody bedwets, correct?
Yes, Doc. Yes, Doc.
So do you remember the smell of urine in the bed? That's how a patient with uremia would smell. Okay. Now, since the main avenue of urine excretion is the kidneys, um, but if you have kidney failure, the urine cannot be excreted out. So what does the urine do? The urine seeps into the third spaces and through the skin, and that's why. So, can I continue?
Yes, Doc. You can.
Can you, if you're not lecturing, can you just switch off your microphone? Because I get distracted with other noises. So as I was saying, since your urine will be excreted, the main avenue for excretion of urine is filtration through the kidneys. But if your urine cannot be excreted because of renal failure, the urine tries to seep into the third spaces and through the skin. So you'll be having urine seeping through the skin, and when you have that, um, then that's uremia. You will have the smell of urine in the room. So only one patient with renal failure, the smell is typical. Did you follow me? What are other signs of uremia? Can I volunteer? Volunteer? Hey guys, am I talking to all here? Can you volunteer?
Hey, Doc, I'd like to volunteer, Doc.
Go ahead.
These were just based on my previous experiences, sir. So I have handled uremic patients, and mostly they are lethargic, no. And then, if not lethargic, they complain of doc. They are mostly confused, disoriented, and such, doc.
Okay. So confusion, lethargy, what else? If you cannot put out urine, what happens to your
No.
If I may share, Doc.
edema is correct? Okay. So if your lab results are increased, if your NPNs are increased, your ABCs are increased, plus edema, then you are in a uremic state. Do you follow me?
Yes, doc.
Okay. So asthenia plus physical signs and symptoms of um, present equals uremia. Okay. Do you follow me? So, um, for our sake of discussion, and if we follow Degoin, anuria is defined as a urine output for 24 hours of 0 to 50. Please take that down. And oliguria is defined as more than 50, less than 450. That is the term called oliguria. Normal urine output is 500 to 2000 ml. So any value that is more than 2000 ml is considered as polyuria. Do you follow me?
Yes. No.
Again, so when you have the prefix a, it means without. Okay, so if the value is less than 50, more than one, less than 50, then the value is anuric. If the value is 50 to between 50 to 450, then the value is oligoric, and between 500 to 2 liters, then that is normal. Any value above 2,000 liters, I mean 2,000 ml, is polyuria. Are we okay?
Yes, Doc.
Okay. So for nephrotic syndrome, you don't find lipids in the urine, so that gives you a what do you call this, distinguishing factor. Anytime that you find lipids in the urine, that the condition is nephrotic syndrome.
That's fine.
Now, in my context, what I want to do is I want to give you my life experience with this condition. Okay, for nephrotic syndrome, when I was young, a little boy, I had a friend in elementary school. He was pale, and I envied him because his urine was red and my urine was yellow. And I was asking him, um, what 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 ice cream did he take, or what ice candy did he take? I wanted my urine to be like his because everybody had yellow urine. He was the only one having reddish urine. And then a few months, he disappeared. And then the next thing I knew, he was dead. So, most probably he had RPGN, rapidly progressing glomerulonephritis. So, it's not good to have any other color for urine, especially when you are young and especially when you are male. For nephrotic syndrome, my context is we were all medical students. There was 100 of us, and we only had one patient who had nephrotic syndrome, a little boy, maybe 4 years old. And every time the group would interview him, the boy became proficient with his disease. And when my group was interviewing him, my groupmate asked me, Pete, what's hupung in English? And then the little boy was the one who answered,
Edema, Doc.
edema. I know. But it was the little boy who answered because we were interviewing him almost always, and several group was passed, and he knew the disease, he knew the terms. So when my classmate was asking me, what is hupong? It was the little boy who answered edema. Okay, so again, going back to this slide, what is important is nephritic syndrome. What you want to think about is hematuria. Nephrotic syndrome, what you want to think about is lipiduria. Do you follow me? Okay, let's move on. So, how do you diagnose hematuria? You do renal biopsy. This is good to know, but not very important. You can do immunofluorescence studies, and you can do electron microscopy. Again, good to know, not very important. let's take up the nephritic syndrome. And the first one is your post-streptococcal glomerulonephritis. It's very important to know the other names. You have your acute proliferative glomerulonephritis and post-infectious glomerulonephritis. Clinical features. This is decreasing in the United States. Children are more affected than adults. It occurs 2 to 4 weeks after streptococcal infection of the throat, and also streptococcal infection of the skin. Okay. The organism is hemolytic group A streptococcus. It may be caused by other bacteria and other disease. So what am I trying to say here? There has to be a prodrome. Do you follow me? Okay. So the child gets sick by a bacterial infection, and then after 2 weeks he develops reddish urine. Do you follow me? Okay. Yes. Omar, are you there, Omar?
Yes, Madam.
Okay. So, for discussion's sake, aside from laboratory tests, what is the most important to diagnostic implement to use to diagnose post streptococcal glomerulonephritis? One word only.
Culture.
Any volunteer?
Culture, Doc.
Culture. No other
History,
laboratory
Doc.
test.
History, Doc.
What?
History, Doc.
History.
Okay.
History is correct. Okay, so if you are able to extract the history of previous infection before hematuria occurs, then that will give you an inkling that the condition is post-streptococcal glomerulonephritis. I would like to emphasize that the etiologic agent is hemolytic group A streptococcus. Okay? Do you follow me? That's the number one. In our context in the Philippines, some patients may have pyodermatous. The Visayan term for pyodermata is what do you call this? Nuka. Have you seen children with pyodermatous affecting their legs? These are this is what is known as nuka in Cebuano, but in English the term is pyodermatous. So if you have pyodermatous and then you develop hematuria, then that is post-streptococcal glomerulonephritis. Now this one is called nephritic syndrome, falls under nephritic syndrome, and the diagnosis will involve elevated anti-streptolysin O titers, ASO titers. I think those medtechs are aware of this. You have low serum complement. And then in light microscopy, there is hypercellular glomerulus with neutrophils and monocytes. Mind you, the glomerulus is cellular, but if you have increased number of inflammatory cells, then this will give rise to glomerulonephritis. Now, is this an acute condition or a chronic condition? Any volunteer?
Acute, Doc.
Acute. Why? Why?
Infiltration the neutrophils and monocytes.
Yes. When the condition is an acute condition, the inflammatory cells involved are usually neutrophils. Okay. So when you're dealing with bacterial and acute conditions, the count that is elevated is neutrophils. However, when you're dealing with lymphocytes, usually it's viral or usually it's a chronic condition. Now, this is a bread and butter lecture, so please understand that it's going to be very useful in practice. So if you have any inflammation, the condition is usually inflammatory and not cancerous. So if you have a condition that is, you can find a lot of inflammatory cells, usually the condition is not cancerous. It is inflammatory. Do you follow me? And if it is acute condition, the predominant cell is neutrophils, or if it's a bacterial inflammation, and if it's a chronic condition, then the inflammatory cells are lymphocytes and as well as viral infection. So let me move on. So you are going to have red cell CAS. So I will introduce more data. Can I do that? Yes? Yes?
Yes.
Okay. So when we're talking about CAS, the normal CAS is your hyaline CAS, okay? And then this will give rise to your granular CAS, which your WBC CAS and RBC CAS will fall under. You have your finely granular CAS, and then you have your coarsely granular CAS, and then you have your waxy CAS. Okay. Now, when you have a hyaline CAS, that is normal. Okay. But when you have a waxy CAS, that will tell you that the condition is chronic. Do you follow me? Okay. So if you have a RBC CAS, then that is an acute condition. Okay. Anytime you have a waxy CAS, that will give you a chronic condition. Okay. Now, immunofluorescence will give you granular deposits of IgG, IgM, and C3, and these are known as your subepithelial humps. Okay. So, electron microscopy, you can see the subepithelial humps. Treatment is conservative. This is a picture of your subepithelial humps. You have like a camel's humps. Camel's hump. Okay, you can see this in electron microscopy. And the prognosis is for children, without treatment, there is recovery in 95% of cases.
Without or with?
Only 1% will go into RPGN, and chronic glomerulonephritis about 2%. However, in adults, without treatment,
Without.
complete recovery is achieved in 60%, and then the rest 40% will go into chronic or RPGM, chronic renal disease. So without any treatment, the patients will recover. Well, the economics of this is a part of one other part of my hat is I'm a PASCO accreditor, and I go around the country accrediting medical schools. And when I was in Luzon, in the northern part, they have families that are they have like 15 to 17 children, one family. So can you imagine that? And if you are the physician, it's up to you if you want to go aggressive or if you want to just consider the history. But in some contexts, when you have only one child and he develops hematuria, I think you have to be very aggressive. Do you follow me? High value child, you have to treat aggressively for hematuria. Okay, so if you are able to extract a history of streptococcal throat infection or skin infection, and then the patient develops hematuria, then you have your diagnosis. And to confirm this, you have your ASO, and you can do electron microscopy. But history alone will give you an inkling that this case that you're dealing is your post-streptococcal or acute infectious glomerulonephritis. Do you follow me?
Yes, Doc.
Are we okay? So what's the highlight for this condition? Number one is history. You can be able to extract the history of 2 weeks infection and then hematuria. Number two is laboratory tests. You will see this will be elevated with ASO titers and the streptolysine O. Number three, the most common infectious agent that is implicated is your group B hemolytic strep. Number four is that you will see epithelial humps. Do you follow me? Number five is the prognosis. For children without treatment, it is 95% complete recovery without treatment. For adults, it's only 60%. That's why you have to be aggressive if this develops in adults. Do you follow me? So this is the highlight of your post-streptococcal or acute glomerulonephritis. Are we okay?
Yes, Doc.
Can I move on?
Yes, Doc.
Yes, Doc.
Yes. The next disease is your good posture syndrome. And yes, Adiola. How many O's are there in good?
You can confirm it. 2.
Yes, go ahead. Mr. Adiola or Miss Adiola?
Yes, Doc.
Yes, how many O's are there in good?
2 goals at the
Very good. Okay, so this is what I want you to remember. Good posture syndrome, there are two O's in good posture. It's type 2 hypersensitivity reaction. Do you follow me? Okay? So anytime you see two O's in good, that is your good posture syndrome, that is known as your anti-GBM disease. It is autoimmune. So, what is the pathogenesis? There are anti-GBM antibodies, okay? And this will result into the damage of the lungs and the kidney, okay? Do you follow me? Now, when your kidney is damaged, it will affect the adjacent organs, especially the lungs and especially the liver. So, if you're given the choice in your assessment exam, and the organs that are going to be asked that will be implicated in renal diseases, your answer should be two. Number one is your liver, and this is known as your hepatic renal syndrome. Number two is your lung. This will give you your good Pastor's disease and your Wegener's granulomatosis. Do you follow me? Can I move on? Okay. Now, good Pastor's antigen is a component of type 4 collagen. So again, this is important. Okay? Okay. But when you see, anytime that you see anti-GBM antibodies, you're dealing with good Pastor's syndrome.
Okay.
It affects more males than females. Peak incidence is between 20 to 40 years. And pulmonary involvement typically precedes renal disease. So, you have hemoptysis, and then you have hematuria. That is your good Pastor's disease. However, if it is the flip side, if you have hematuria first and then renal disease, that is your Wegener's granulomatosis. Do you follow me? So the sequence is important. Again, if you have hematuria first and then hemoptysis, that is your Wegener's granulomatosis. But if you have hemoptysis first and then you have hematuria, that is known as your what they call this, your anti-GBM or your good Pastor's disease. So the sequence is important. Do you follow me? Can I move on? Okay. Now, the sequelae is it is the number one cause of rapidly progressive glomerulonephritis. Okay. Okay. And there is going to be hypercellularity presence and fibrin present in rapidly progressing glomerulonephritis. And then what happens is in immunofluorescence, there's a smooth linear pattern of IgG and complement C. And treatment is plasma exchange, steroids, and cytotoxic drugs. Prognosis is poor. Pulmonary hemorrhage might be severe and life-threatening. And RPGN is the most common sequelae. Okay? So you have to be aggressive in patients with end-stage renal failure. Okay? So you don't want to go to the stage. So when you have hemoptysis and then you have what you call this hematuria, then you're most probably dealing with Bushmaster syndrome. Okay. So I need a volunteer, a Filipino. So let's ask Greta. Greta, are you there?
Hi, Doc.
So if you're in a barangay, if you become an from what province are you, Greta?
I'm from Eastern Summer, Doc.
Okay, so you graduated from Southwestern University School of Medicine. You get assigned as a municipal health officer in one of the remote areas in Eastern Samar. And one day you have a patient that comes, um, and you were able to extract patient having hemoptysis and then developing hematuria. Um, what will you do, or how will you diagnose the patient?
Um, I'm not exactly sure, Doc, but
Yes.
so given Doc nga ang place kay walay mga pang-test ing anak, Doc, or
Can you talk louder, please?
hello, Doc. So is it given, Doc, that the place doesn't have kanang mga laboratory tests or naa or
You're in a remote area.
in a remote area? So do I so from what I have learned so far, Doc, I'm not well versed, Doc, with the clinical pathology side since um but do I check for the history of what came first?
Yes, the history is the patient had hemoptysis first and then developed after 2 weeks hematuria.
Mm,
Yes. So what's next? What's the next step you want to do?
um so if there is an available, Doc, na urine dipstick, Doc, can I will I be able to use it, or
So you use a urine dipstick and it's positive for RBC.
then it
What's the
would
next step? What's the next step to do?
I'm not so sure, Doc, but from what I have read, kay it would point to glomerulonephritis, Doc, if nag-positive with the RBC casts. Oh, like if it nag-positive.
Um, that's you diagnose immediately glomerulonephritis. What about the kidney stones?
I'm not so sure, Doc. I apologize, Doc.
Yeah. So what's the next thing to do? If you want to have the diagnosis, what's the next thing to do?
Um, can I refer, Doc, the patient? Para magpa ultrasound.
Your answer is correct. So what you want to do is you extract the history and then put a referral note and refer the patient to a center that can document and diagnose the condition for you. Do you follow me?
Yes, Doc.
Since you being a municipal health officer don't have the uh, diagnostic implements to make the diagnosis. Do you follow me?
Yes, Doc.
Okay. Okay. So again, when you have hemoptysis and then when you have um, glomerulonephritis, then if you have hematuria after your hemoptysis, then that is your um, good pasture syndrome. Do you follow me? Okay. So any condition that is associated with the with presence of anti-GBM antibodies, your diagnosis is good pasture syndrome. So in the board exam, you have a lot of clinical vignette, and then you will see the word positive for anti GBM antibodies. Then your answer is automatic. The answer is good pasture syndrome, and the most common sequelae is um, renal failure, rapidly progressing glomerulonephritis. Do you follow me? So again, good pasture syndrome is autoimmune. It is type 2 hypersensitivity reaction. Hemoptysis comes first before hematuria, and this is a nephritic syndrome. And the most common sequelae is rapidly progressing glomerulonephritis. Those are the highlights. The treatment is important. You have to be aggressively treating the patients with um, steroids and other treatment that you need to do. Do you follow me? Can I move on? Are we okay?
Yes, Doc.
Yes? Okay. The next one is your crescentic glomerulonephritis. Okay? Now, if you take a look at this, you will have the glomerulus here. Can you see my pointer? Yes? Yes?
Yes, Doc. Yes, Doc.
Okay. Now, if you take away the glomerulus, you are going to see a half moon or a crescent. Okay. So this is your crescentic glomerulonephritis. There is leakage of material, of proteinaceous material in the glomerular space. So if you take away the glomerulus, you're going to have a crescent. Okay. For the sake of discussion, it's very important to remember that when there's a crescent, the condition is not good anytime. Do you follow me? Okay. So this is the your kidney, your glomerulus in your kidney, and normally it is cellular. But when you have what we call this glomerulonephritis, you're going to have a hypercellular glomerulus. Okay, so there's going to be a lot of inflammatory cells, and when your inflammatory cells are neutrophils, then you're dealing with an acute condition. If you're dealing with a chronic condition, then you are going to have a lot of lymphocytes. So normally the glomerulus is cellular, but it becomes hypercellular, then the term is glomerulonephritis. Okay. Now, let's go to rapidly progressing glomerulonephritis. This is the most common sequelae of good pasture disease. And the most common cause is good pastures, and then this is going to be followed by other forms of glomerulonephritis. Your post-infectious glomerulonephritis can happen in 5% of cases in children. In adults, it's 40%. That's why you need to be aggressive with adults. Do you follow me? Okay. It can be associated with vasculitis. Okay. When you have hematuria first, and then you have hemoptysis, that is your Wegener's granulomatosis. Okay, so please remember the sequence. Sometimes it's idiopathic, so you don't know the cause. The diagnosis is you have a hypercellular glomeruli. There is crescent formation in the Bowman space. That is a giveaway. So when you see the word crescent, it is crescentic glomerulonephritis or rapidly progressing glomerulonephritis. Do you follow me? Okay? Okay. Now, this is a board question and it came out. What is the source of your crescents? It is a leakage of protein from parietal epithelial cells. So please do not miss this. Okay. Immunofluorescence is variable. You are going to have granular or linear deposits of immune globulin. And for electron microscopy, the result is variable. So when it's variable, it's not very important. Okay. So what is the source of your crescents? It is proteinaceous material from your parietal cells. Do you follow me? Okay. Okay. Prognosis is poor. This will lead to acute renal failure and renal disease. So when you have been diagnosed as RPGN, the prognosis is within weeks to months you'll have renal failure. So can you imagine my context? My friend, when I was elementary, he had rusty urine, and after 2 months he died. So usually when you have patients, okay, eventually some of you are going to be mothers, some of you are going to practice pediatrics. When you have a child that is sick, it's very important that you take aggressive measures when the child is sick. Why? Because the child's condition is very labile. So I've learned my lesson. I was not able to manage a pediatric patient well. The patient died as a consequence of my mismanagement. So I don't want you to have this experience this situation, because you are going to always remember this. Do you follow me? Okay. Okay. So again, when you have RPGN, in 2 weeks to months, you're going to develop renal failure. And what is the treatment? The treatment is dialysis. Okay. Now, what's the economics for patients with dialysis? The patients with dialysis is hard. Why? Because it is going to consume almost all of the resources of the family. You do dialysis maybe 4 times a month, and the cost is about 7,000 pesos, I think, per session. And can you just imagine having dialysis for 1 year? It's going to cost hundreds of thousands of pesos, and it's going to drain the family resources. Okay, so you don't want to have this problem. Do you follow me? Okay. Now, there are 3 types of RPGN. You have your type 1, which is 25%, and this is anti-GBM positive. When you see the word anti-GBM, what disease are we talking about?
Good pasture.
Excuse me?
Good
Good pasture syndrome daw.
Good pasture syndrome. Correct. Very good. And what type of hypersensitivity is good pastures?
Type 2.
Type 2 daw.
Type 2. Correct.
Type 2
Very
daw.
good. Now, this may have a pulmonary component. And what's your differential when you have renal disease and hemoptysis? There are two. Good pastures and what?
Wegener syndrome.
Wegener
granulomatosis.
Correct. Correct. Very good.
Granulomatosis.
Okay. There's also a high prevalence of HLA subtypes. And type 2 is your immune complex mediated. Now, you have when we're talking about hypersensitivity reaction, you have type 1, which is your immediate, and you have your type 4, which is your delayed. You follow me? And then you have your type 2, which is your cytotoxic type, and this is where your when your good pasture syndrome is falls classified under. And then type 3 is your immune complex mediated. So the way you're going to do it is so you just remember type 1 is immediate, type 4 is delayed, and then good pasture is type 2, and then you have your immune complex mediated, which is your type 3. Do you follow me? Now you have your lumpy, bumpy, granular staining, patterns of staining for RPGN. But the number one diagnosis is presence of crescent, which can be seen microscopically under light microscopy. Okay. Now the most common type is your pauci-immune type. When you see pauci, what does it mean?
Little.
Yes. So when you have remember your kidney is cellular, but when your kidney becomes acellular, what happens is your kidney cannot uh, function anymore because there are no cells. This is your pauci-immune type. This is the most common type of RPGN. So you have your anti-GBM, which is 25%, type 1. Type 2 is your immune complex mediated, and then you have your pauci immune type. Meaning to say that if there are no more renal cells, your kidneys cannot function. Do you follow me? Okay? Okay. This is anti-GBM negative. However, this is positive with your ANCA or your anti-neutrophilic cytoplasmic antibodies. This is ANCA positive. Do you follow me? Usually associated with Wegener's granulomatosis. Okay. And then the next one is your Berger's disease, your IgA nephropathy. Okay. Now, when we're talking about anaphylaxis, there are two immune globulins that are involved. You have your IgE and your IgA. Your IgE is increased, this will result into anaphylaxis. When your IgA is decreased, that will result into anaphylaxis also. Do you follow me? Okay? It's not only IgE, but a depletion of your IgA is associated with anaphylaxis. Are we okay, guys? Okay. Now, another question is, what is the most common immune globulin that is going to be deficient? The answer is IgA, apple. Do you follow me? Okay. So the next one is your Berger's disease. And this is the most common cause of glomerulonephritis in the world. Okay? Usually occurring in France, Japan, Italy, and Austria. Usually children and young adults, maybe the age of 20 to 25, are affected. Okay? Okay. And there is hematuria for Berger's disease, and this will be secondary to a respiratory prodrome. So if you have a flu-like symptom, and then you have a respiratory infection and you develop hematuria, that is your Berger's disease. Other disease association include celiac sprue and Henox-Coyne purpura. The mechanism is unknown as to pathogenesis. When you see the word unknown, it is known as idiopathic. There is one second. There is possible entrapment of circulating immune complexes, and the immune globulin that is affected is your IgA. Light microscopy, the result is variable. So again, this is not important. There might be normal or mesangial proliferation. And this is a giveaway. So if you have mesangial deposits of IgA, the result, the disease is known as Berger's disease. Do you follow me? Okay. Prognosis is renal failure over 25 years. Okay. Now, so if you have a patient with Berger's disease, how will you break it to the patient? Any volunteer? Yes, any volunteer? No volunteer? Any volunteer, guys? You.
Hello, Doc. Could you repeat the question, Doc? If we have patients with renal disease, how can we?
If you have a patient with Berger's disease, how will you break it to the patient?
How should I deliver it to them, Doc?
Excuse me?
How should I deliver it to them?
Yes. Of course, you're not going to say, hey, congratulations, you have Berger's disease. How will you tell the patient? I have good news and bad news for you. You have renal disease, but you're going to live for more than 25 years before your kidney fails. Is that how you're going to do it?
No, Doc.
I will let you off the hook. I asked this question a long time ago, and one of my students